Welcome to SurgiSmart. This is part 1 of 4 of Gastric Polyps series. This includes Introduction, Etiology, and Epidemiology of Gastric Polyps.
It's great to be here. This is a surprisingly complex topic.
It really is. You know, when we started prepping for this deep dive, my mental model of a gastric polyp was, well, pretty simple. I imagined a patient, waking up from a scope, a bit groggy, and the doctor just holds up a picture of this little generic bump and says, "We found this, we clipped it, you're fine." Very transactional.
That is absolutely how it feels for the patient, and often how it's presented. It's that snip and forget moment.
But the more I looked at the research, that bump it's more like a geological formation. It's a historical record.
I love that analogy.
Yeah.
Geology.
Yeah, it tells you exactly what the weather's been like in that stomach for the last decade. It tells you about the bacterial ecosystem, the genetic mutations that might be bubbling under the surface.
And critically, it tells you a lot about the pharmaceutical industry.
Absolutely.
Medically, you're right. We have this very dry definition for them, projections of mucosal or submucosal tissue into the stomach lumen.
Right.
But you're spot on. They are symptoms of an environment. They're the result of a specific set of pressures. And whether those pressures are, inflammatory, genetic, or chemical, the polyp is the endpoint. It's not the beginning of the story.
And this isn't some rare, exotic landscape we're talking about. This is a crowded field.
No, not at all. If you look at the general population estimates, you might see a prevalence figure of around 2%.
But that feels a bit misleading.
It is, because that includes everyone walking around who's ever had a camera down their throat.
Right, because you don't feel a 3-millimeter polyp. There's no pain signal coming from a tiny tag of tissue.
Precisely. So the number that matters more, the clinically relevant number, comes from the endoscopy suite. When we perform an EGD and esophagogastroduodenoscopy, we're actually finding polyps in about 6% of all cases.
6%.
In the high-volume center, that means you are seeing this pathology multiple times a day, every single day.
And the context for that discovery is usually incidental, right? I mean, people don't book an appointment saying, "Doc, I think I have a Fundic Gland Polyp."
Almost never, no.
Yeah.
They come in for the big quality of life issues. GERD is the number one.
Reflux.
Reflux, yeah. Or dyspepsia, which is really the catch-all term for my stomach hurts and I just don't know why. Anemia is another really common driver. So we go in looking for an ulcer or the source of the reflux, and while we're panning the camera around, boom, there it is. We spot a lesion.
Which brings us to what I think is the first major hurdle that all the literature points to, the optical biopsy. You're looking at a high-definition monitor, you've got magnification, narrow-band imaging, all this tech.
All the bells and whistles.
Can you trust your eyes?
Yeah. You can have a very, very educated guess. You can look at the color. Is it red and angry looking, or is it pale and glassy? You can look at the shape. Is it sessile, meaning it's flat against the wall like a blister?
Or pedunculated.
Or pedunculated, hanging from a stalk like a little cherry. But the short answer is no. Visual diagnosis alone is notoriously unreliable.
So you can't just say, "That's benign," and move on.
You can't. You should not. You have to take the tissue. Histology, looking at it under the microscope, that's the only truth serum we have in this game.
Because, and we'll get to this later with the zebras, some very scary things can dress up like very innocent things.
Exactly.
But before we get everyone worried, let's map out the main continent here. The source material is very clear that 3 specific types of polyps really dominate the gastric landscape.
That's right. If you can really grasp the mechanics of Fundic Gland Polyps, Hyperplastic Polyps, and Adenomatous Polyps, you basically understand 90% of what's happening in the stomach.
And they're all classified histologically.
Yep, based on which layer of the stomach wall they're sprouting from. It's all about the tissue of origin.
Okay, so let's start with the one you called the modern era polyp, the undisputed king of the modern stomach, the Fundic Gland Polyp.
The modern era polyp, yes.
That sounds like a Time magazine cover story. Why that name?
Because its rise to dominance, its epidemiological curve tracks almost perfectly with the adoption of the Western lifestyle and, even more specifically, Western medicine's approach to stomach acid.
So these are the most common ones we find now.
By far. They typically reside in the body, and the fundus, that's the upper reservoir of the stomach, where the acid is made.
And visually, they have a certain look, don't they?
They do. They're usually pretty distinct. They tend to be small, 1 to 8 millimeters, give or take. They're sessile, so flat and smooth, and they have this glassy, almost translucent appearance.
Like water droplets.
Exactly, like little water droplets caught just under the mucosa. They look harmless.
But under the microscope, it's a completely different story. It's a plumbing disaster.
That is a fantastic way to put it.
Mhm.
Histologically, what you're seeing are dilated, irregularly budded fundic glands. The very glands that are supposed to be secreting acid are swollen up and cystic.
Which leads us directly to the so what factor here, which for me was the most compelling part of the epidemiology, the link to proton pump inhibitors,
Hmm.
PPIs.
Ah, yes.
This isn't just some vague association. The data is incredibly strong.
It's definitive at this point. There's a prospective cohort study that gets mentioned in almost every paper on this, and the numbers are just staggering. It showed that the risk of developing these polyps increases significantly with the duration of PPI use.
I want to really double click on that number because
Yeah.
it blew my mind. A relative risk increase of 17 over 10 years.
A 17-fold increase. I mean, think about that. In the world of epidemiology, we usually get excited about a 2-fold, maybe a 3-fold increase.
Right.
17 is a megaphone. It is screaming at you from the data. And that's not all. It's supported by other data, like a retrospective analysis of 186 patients that showed that once you cross the 5-year mark of daily use, that's the tipping point. The incidence curve just shoots upward.
And the mechanism seems to be this feedback loop that's gone completely haywire.
That's the theory.
You take the pill to stop the acid. The stomach realizes there's no acid, so it either tries to overcompensate, or the glands simply get blocked up because the secretions aren't flowing properly.
It's likely a combination of factors. There's a big theory involving gastrin. That's the hormone that tells the stomach to make acid. When you suppress the acid with a PPI, your gastrin levels skyrocket to try and whip the stomach back into action.
That trophic effect.
Exactly. That trophic or growth effect might be causing the glandular hyperplasia. Or, like you said, it could just be a mechanical blockage of the parietal cells. The pipes are clogged.
There was a case study in the source material that really humanized this data for me. A 37-year-old woman, and this wasn't an incidental finding for her, she was really sick.
Yes, she presented with hematemesis,
Vomiting blood.
vomiting blood, which is a terrifying symptom for anyone, especially a young, otherwise healthy person. They scoped her, and they found her stomach was just full of these multiple fundic gland polyps. But the key piece of history was her medication list. She'd been on PPIs for years.
And the treatment wasn't surgical, it was just stopping the pill.
That's the beautiful part of the story. They stopped the PPI, they rescoped her later, and the polyps had regressed. They had actually shrunk significantly.
It proves the causality.
It absolutely does. In the sporadic form, and by that I mean in generally healthy people without an underlying genetic syndrome, these polyps are very often a direct side effect of medication.
Okay, but we have to talk about the exception, the genetic dark side of the fundic gland polyp. Because not all of them are just from Nexium or Prevalenced.
No, and this is where taking a good family history becomes absolutely vital. Most FGPs, the sporadic ones, carry a negligible cancer risk.
Right.
We don't really worry about them. They don't follow that typical pathway to malignancy. But if you see a patient with familial adenomatous polyposis, or FAP,
The entire game changes.
completely. FAP is a hereditary syndrome where patients are genetically predisposed to develop thousands of polyps in their colon, but it's not just the colon, they get them in the stomach too.
And in these FAP patients, the fundic gland polyps are not innocent bystanders.
Far from it. They're numerous, we call it carpet bombing, the
Yeah.
fundus. And here's the scary part. Up to 40% of them can be dysplastic.
And dysplastic means they are starting to show those early cellular changes, the precancerous changes.
Precisely. And the genetics here are so fascinating. Even the benign sporadic polyps you find in regular people often have mutations in the APC gene,
Wait, that's the same gene involved in FAP.
the very same gene.
So hold on, I might have a polyp in my stomach right now with a broken APC gene, but it's benign.
Yes, there was a great study that compared 147 people. It found that while those sporadic polyps have the APC mutation, they lack the second hit. They don't have the chromosomal instability needed to progress to cancer.
But in FAP patients,
That instability is baked right into their DNA. So the takeaway is this. If you see a young person and their stomach is carpeted with these smooth, glassy polyps, you have to stop and think FAP immediately.
okay, that makes sense. Let's pivot now to the second member of the big three, the hyperplastic polyp. In our pre-show notes, you called this the reactionary polyp.
I did. Because unlike the FGP, which is often a plumbing issue, the hyperplastic polyp is more of a scar tissue issue. It is a direct response to injury.
So visually, how would we tell them apart from those glassy fundic ones?
Location is your first clue. Big time. While fundic polyps like to hang out upstairs in the body in fundus.
Hyperplastic polyps prefer the basement, the antrum.
Exactly, the antrum, that lower part of the stomach, just before it empties into the small intestine.
And they look different, too.
They do. They're characterized by something called foveolar hyperplasia. Now, just imagine the skin of the stomach thickening up like a callus. The cells that line the pits, the foveolae, they overgrow and they get elongated and distorted.
So they're bigger.
Generally, yes. These polyps can be sessile or pedunculated, and they're often larger than fundic polyps, frequently pushing up toward 2 centimeters in size.
So if they're a response to injury, what's the weapon causing the wound?
Historically, the #1 culprit was Helicobacter pylori.
The bacteria that changed. Everything in gastroenterology.
It really did. H. pylori causes chronic active gastritis. It's
Yeah.
a constant low-grade inflammation, especially in the antrum. The body tries to heal that inflammation, it overshoots the mark, and it builds a polyp.
So finding a hyperplastic polyp is almost a diagnostic proxy for finding gastritis.
It's like seeing smoke and knowing there's a fire somewhere nearby.
Got it.
And that smoke can signal other things too. We see them a lot in the setting of pernicious anemia or even just severe iron deficiency anemia. In fact, sometimes these polyps can get so large and fragile that they ulcerate at the tip and start to bleed, which then causes the anemia themselves, a real chicken and egg problem.
So what's the verdict? Are they dangerous or just annoying little indicators of bad bacteria?
They're trickier than sporadic fundic polyps. The malignant potential is real. It's not huge, but it's absolutely not zero.
Is there data on that?
There is. A key retrospective cohort study looked at 195 patients with hyperplastic polyps.
And what did they find?
In that group, they found low-grade dysplasia in 5 patients, high-grade dysplasia in 4, and 1 patient had a frank adenocarcinoma, an invasive cancer, hiding inside the polyp.
Okay, 1 out of 195 doesn't sound like a lot, but if you're that one person,
It matters immensely, and we do have risk factors to help us stratify that risk. Size is the big one. If the polyp is larger than 25 millimeters, so 2.5 centimeters, the risk jumps up significantly.
and the neighborhood matters too, right?
The neighborhood is everything. If the surrounding stomach tissue shows signs of intestinal metaplasia, that's a very bad sign.
I want to pause on intestinal metaplasia because that term comes up constantly in any discussion about gastric cancer. It sounds like the stomach is having an identity crisis.
That is essentially what it is. The stomach lining is under so much chronic stress from inflammation that it basically gives up. It decides to swap out its normal specialized stomach cells for more generic, tougher intestinal type cells.
As a defense mechanism.
As a defense mechanism, yes, but that cellular confusion, that metaplasia, is fertile ground for mistakes in DNA replication. And those mistakes are what lead to dysplasia and eventually to cancer.
Which is the perfect segue to the third big player, the one that I imagine keeps gastroenterologists up at night, the adenomatous polyp.
The warning sign.
With the other two, we've been talking about potential for trouble. With adenomas, the trouble is already there, isn't it?
Correct. By definition, a gastric adenoma is a neoplastic lesion. It is a direct precursor to adenocarcinoma. It demonstrates low-grade glandular dysplasia from the very moment it exists.
It's not reacting to the environment anymore.
It has mutated. It's on its own path now.
And where do we usually find these ticking clocks?
Usually in the antrum, similar to the hyperplastic ones. They're often solitary and sessile. But the risk profile here is serious, especially if they have what we call villus features.
Villus-like, shaggy, like a carpet.
Exactly. Under the microscope, instead of being smooth, they look like they're made of long, shaggy, finger-like fronds. And large villus adenomas have the highest risk of harboring an invasive cancer that's already hiding within them.
And the cause, the etiology, it links back to that same hostile environment we were just discussing.
It does. It's the end of the road. They arise from that background of chronic atrophic gastritis and intestinal metaplasia. It's the final result of a stomach that has been under siege, usually for decades.
Which would suggest that age is a major factor here.
Yes. This is typically a disease we see in older adults.
So let's run a scenario. I'm scoping a 25-year-old for some vague abdominal pain, and I find a clear adenoma.
That is a massive flashing red flag. You stop everything and you start thinking about genetics. Finding an adenoma in a young person is highly, highly suggestive of an underlying syndrome like FAP.
So you're not just taking out the polyp.
No. You're now obligated to look at their colon. You need to take a detailed family history. It triggers a whole cascade of other investigations.
So we have our big three: Fundic Gland Polyps, the PPI side effect, Hyperplastic Polyps, the scar from the bacterial war, and Adenomatous, the precancerous mutation. That covers most of the map.
It covers the mainland, yes. But now we have to talk about the islands out there, the zebras, the rare but important lesions.
I do love the rare stuff. Let's start with neuroendocrine polyps, or NETs, because this isn't just one disease, is it? It's a whole family.
No, and treating them as one disease is a very dangerous mistake. NETs, they arise from the ECL cells, the enterochromaffin-like cells.
These are the cells that listen to gastrin.
They're the middlemen. Gastrin tells the ECL cells what to do, and the ECL cells then tell the parietal cells to make acid.
And the source material breaks them down into 4 distinct types. It seems like distinguishing between type I and type 3 is the most critical distinction to make. The prognosis is night and day.
Absolutely. Let's start with type I, because it's the most common, accounting for maybe 70 to 80% of all gastric NETs. And strangely, it's driven by the body trying to help itself.
This goes back to that autoimmune mechanism again.
Yes, in autoimmune atrophic gastritis, the body's own immune system destroys the parietal cells, the acid-producing factories. So no acid is made. The stomach senses this lack of acid, this aclohydria, and it panics. It starts pumping out massive amounts of gastrin to try and stimulate acid production.
But there are no cells left to respond to the signal.
Correct. The parietal cells are gone, but the ECL cells are still there, and they do respond to that screaming level of gastrin. They start multiplying like crazy.
Which leads to hyperplasia and then these little tumors.
Exactly. So type I NETs are usually multiple, they're small, and you find them clustered in the body or the fundus. And because they're hormone-driven, they tend to be indolent, they grow very slowly, they rarely metastasize.
Now contrast that with a type 3.
Type 3 is the bad actor. It is sporadic. It has nothing to do with gastrin levels, nothing to do with gastritis. It's just a rogue clone of cells that decided to become a tumor.
And it presents differently.
Very differently. It's usually a solitary lesion, not a cluster. And it is dangerous. Even at small sizes, these type 3 tumors have a significant risk of metastasizing to the lymph nodes or the liver.
So if a pathologist just writes neuroendocrine tumor on the final report, that's not enough information.
It's not nearly enough.
Yeah.
You have to ask the next questions. Is the gastrin level high? Is there evidence of autoimmune gastritis? Because the management is totally different. If it's type 3, that patient might need a partial gastrectomy. If it's type I, you might just watch and wait.
Okay, that's a crucial distinction. What about the other 2 types?
Type 2 is very rare. It's associated with Zollinger-Ellison syndrome and the genetic condition MN1. And type 4 is the nightmare scenario. Poorly differentiated, highly aggressive, and usually lethal. Thankfully, it is exceptionally rare.
Let's go deeper now, literally deeper, into the layers of the stomach wall. We've been talking mostly about the lining, the mucosa. But what about the lumps and bumps that come from the muscle or the connective tissue? The mesenchymal lesions.
Right, these are the ones that can really confuse the endoscopist because the mucosa on top of them often looks perfectly normal. It's just a bulge from below. And the most famous one, the one everyone thinks of, is the GIST, the gastrointestinal stromal tumor.
GISTs are fascinating because they don't seem to play by the normal rules of directionality.
They don't. They originate deep in the wall, in the muscularis propria. They can be malignant. But what's so tricky about them is that they often grow extraluminally.
Meaning they grow outward into the abdominal cavity away from the camera.
Exactly. You might see a small, smooth bulge inside the stomach, but that could just be the tip of the iceberg. The actual mass on the other side of the wall could be huge.
Compare that to a leiomyoma.
So a leiomyoma is a benign, smooth muscle tumor. And in the old days, before we had better staining techniques like Kiket, a lot of GISTs were probably misdiagnosed as leiomyomas.
But they grow differently.
They tend to, yes. Leiomyomas tend to grow intraluminally. They bulge inward into the stomach.
And the size range is just wild. The notes say anywhere from 0.5 centimeter to 20 centimeters.
Imagine a cantaloupe sitting in the stomach. That's a 20-centimeter leiomyoma. But usually they're just small, incidental findings.
Okay, there were 2 other oddities that caught my eye because of their really specific visual descriptions. First, ectopic pancreatic tissue.
This is literally a piece of the pancreas that got lost during fetal development and ended up growing in the stomach wall.
Bizarre.
It is. It looks like a submucosal mass, but it often has a classic tell, what we call central umbilication.
It has a belly button.
It looks exactly like a little belly button,
Yeah.
a central dimple. If you see a submucosal bump with a dimple in the center, 90% of the time it's ectopic pancreas, usually harmless.
And what about granular cell tumors?
Also rare, usually benign. They classically have a yellowish hue to them. And the interesting clinical pearl there is that if you find one in the stomach, you should always take a careful look at the esophagus as well. They like to co-occur in both locations.
This whole tour of the zebras really just reinforces why that optical biopsy concept is so
It
dangerous.
is.
A yellow bump could be a harmless bit of fat, or it could be a granular cell tumor. A bump with a dimple could be pancreas, or it could be an ulcerated cancer that happens to have a central depression.
And this complexity brings us to a really important study out of China that I think just shatters the illusion of the simple polyp.
This was the study of 125 patients, mostly with single adenomas, right?
That's the one. We tend to think of a polyp as being one thing. It's an adenoma or it's hyperplastic. But this study found that in 23% of cases, the polyps had mixed components. You could have a polyp that was mostly hyperplastic, but also had fundic gland elements mixed in.
The hybrid lesion?
It's a hybrid because the stomach isn't a petri dish with only one variable acting on it. It's a messy, complex ecosystem. And in that same study, 50% of the patients had chronic atrophic gastritis. 21% had active H. pylori.
And the most terrifying statistic of all, 13% had synchronous adenocarcinoma.
13%. Let that sink in.
So more than 1 in 10 patients who came in with what looked like a single adenoma also had a separate invasive cancer growing somewhere else in their stomach at the very same time.
Yes, this is the field defect theory in action. The polyp is just the sentinel. It's the canary in the coal mine. And if the canary dies, you don't just replace the canary. You have to check the entire mine for gas.
So if you find an adenoma,
You have to meticulously evaluate the entire gastric mucosa. You're looking for cancer risk, for infection, for atrophy. You are no longer just treating the lump. You are treating the entire neighborhood.
that is a profound shift in thinking. It moves us from polypectomy, the procedure, to patient management, the long-term strategies.
Exactly.
Let's zoom out now and look at the big picture trends. The epidemiology section in our prep material described this shift in dominance that's happening in real time.
It's a perfect case study in how medical intervention and public health can completely alter disease patterns.
So what was the old world like?
Historically and still today, in parts of the world with very high rates of gastric cancer like East Asia, H. pylori is king. So, as you'd expect, hyperplastic polyps and adenomas are much more common.
Up to 10% of polyps in some Asian countries are adenomas, right? That's a huge number compared to the
A
West.
massive number.
Right.
It's because the primary inflammatory driver, the bacteria, is rampant. But now, look at the West. We've declared war on H. pylori, we have better sanitation, and we treat it aggressively with antibiotics when we find it.
And as a result, hyperplastic polyps are disappearing.
They're becoming much less common.
Yeah.
But nature, as they say, abhors a vacuum.
And pharmaceutical companies abhor a lack of sales.
Precisely. We have effectively replaced H. pylori with the proton pump inhibitor. We treat GERD and dyspepsia aggressively and for long periods. So as the hyperplastic polyps decline, the Fundic Gland Polyps have exploded.
What are the numbers on that?
They now represent anywhere from 37% to as high as 77% of all gastric polyps found in Western studies.
That is a total inversion of the landscape in just a few decades.
It is. And the demographics tell the story perfectly. Who takes PPIs? Very often it's middle-aged adults. And who gets sporadic FGPs? Middle-aged women are the #1 demographic. It all lines up.
The source material also broke down the demographics for some of the rarer conditions, which I think is really helpful for pattern recognition.
It is. NET type I, the autoimmune one, overwhelmingly seen in middle-aged women. Why? Because autoimmune diseases in general, lupus, rheumatoid arthritis, and autoimmune gastritis, all have a strong female predominance.
Whereas the really nasty NET type 4
Tends to be found in older men, which sadly is a pattern we see in many aggressive, poorly differentiated cancers across the body.
And what about Cowden syndrome?
Women, typically age 16 to 65. Cowden is a genetic syndrome that's strongly associated with breast, thyroid, and endometrial cancers. That hormonal link seems to place it squarely in that demographic.
One trend that was mentioned as a bit of a mystery is the slight rise of adenomas in the West. We said they're rare, 0.5% to 1%, but they seem to be creeping up. Any theories on that?
There are a few.
Yeah.
It could just be better detection. Our endoscopes and imaging are incredible now compared to 20 years ago. We're just seeing things we used to miss. Or it could be that as our population ages, the cumulative effect of other non-H. pylori inflammatory markers, things in our diet, obesity, shifts in our microbiome, is creating that atrophic, precancerous environment anyway.
Before we wrap up the epidemiology, we have to circle back to the FAP patients one last time. because the numbers are just, they're from a different planet.
It's a completely different universe.
Yeah.
In the general population, finding an adenoma is rare, maybe 1%. In FAP patients, 15% have adenomas.
And hyperplastic.
20% have hyperplastic polyps, and a whopping 68% have FGPs. But again, it's not just the quantity, it's the quality.
The high-grade dysplasia rate is the kicker.
It is. In a general patient, an FGP is 99.9% benign. In one review of FAP patients, high-grade dysplasia was identified in every single polyp type they looked at: fundic, hyperplastic, and adenomatous. The underlying genetic instability means that all the normal rules of benign by appearance just do not apply to them.
Wow. So we have covered a massive amount of ground here. We've dissected the big three, we've hunted the zebras, we've looked at the shifting tides of epidemiology. If you had to distill this all down for the listener, the mission of this deep dive, what is it?
The mission is to realize that a gastric polyp is a storyteller. It's not just a piece of tissue to be snipped and thrown away. It is a clue.
A clue to what, exactly?
To the environment of the stomach. If you see a fundic gland polyp, it tells you a story about medication use and acid suppression.
Yeah.
If you see a hyperplastic polyp, it screams injury, and it points you directly toward inflammation in H. pylori.
And if you see an adenoma,
It warns you of a field defect. It tells you that the entire stomach is at risk for cancer.
so getting a benign on that pathology report is great news, but it absolutely should not be the end of the thought process.
Never. The polyp is the symptom, not the core disease. If you just remove the polyp but you ignore the underlying H. pylori infection or the atrophic gastritis that caused it, you haven't actually fixed the patient. You've just painted over the crack in the wall.
Which sets the stage perfectly for part 2 of our series. Because now that we know what these things are and what they mean, we have to figure out what we're supposed to do about them.
That's the practical application. Evaluation, management, surveillance. When do you re-scope? When do you need to cut a polyp out versus just biopsy it? When you test for genetics, that's where the rubber really meets the road.
I want to leave our listeners with one final thought that I've been mulling over since we started this. We talked about the trade-off. We treat ulcers and reflux with PPIs to prevent pain and, importantly, esophageal cancer. And in doing so, we created this explosion of fundic gland polyps.
The law of unintended consequences, right there in the stomach.
Exactly. And all the data says these FGPs are overwhelmingly benign. But if 6% of EGDs are finding polyps and millions upon millions of people are on these drugs for life, are we absolutely sure we aren't trading one pathology for another down the line? We are altering the fundamental physiology of the human stomach on a global scale.
It is the central question of modern gastroenterology. We currently believe we're trading a very high-risk esophageal adenocarcinoma for a very, very low-risk gastric polyps with minimal malignant potential. Right now, that math works overwhelmingly in our favor.
Good.
But as we see these numbers continue to rise, and as we learn more about the long-term effects of decades of acid suppression on the microbiome and everything else, we have to keep checking that math. We can't afford to get complacent.
We can't get complacent. I think that is the perfect place to pause.